There's a lot of tech advancement and emerging technologies that are looking at improving infrastructure, insurance, provider access, provider tools, all of that stuff. But there's not enough technology or tech development in the space of helping caregivers. Everything focuses on the providers, which, as a provider, I really appreciate that. But the people who really need the help and support are the family caregivers. They are using reminders and notes on their phones or writing things down in diaries, and they're trying to manage all of these appointments and all the different things doctors have told them and all the different medications, and then the medication changes and their side effects, and just trying to hold their family member together while also managing themselves, right? And in many cases, they're caring for more than one older adult, and they're caring for themselves. And so it becomes such a tedious task to manage all that information, and there's not enough development in that space to help support these family caregivers.
Welcome everyone, I'm Arvind Sarin, and today I'm joined by Dr. Pooja Patel, founder of Aging Together and an occupational therapist who's got tons of experience in this field. Pooja, welcome to the podcast.
Thanks so much for having me here.
So you've got such a great experience in this field. Why don't you tell the audience what you do and how you ended up where you are?
Yeah, absolutely. So I am an occupational therapist by trade. I've worked within the hospital systems for about a decade. My latest work has been primarily with older adults and their families, primarily working with their family caregivers. I have a board certification in gerontology with additional training in dementia and fall prevention. So I spend a lot of time working with families to help prepare their homes or prepare their parents for aging in place safely. And specifically, my mission is to make sure that families have plans in place for when a crisis happens.
Wonderful. Yeah, that sounds fantastic. And that's something that, there's not a lot of education out there. And especially the areas where you specialize, I feel like they're such a big contributor to the decline in the health and to, hospitalization and all of that. So, and it's great that you're an occupational therapist. And for the audience, of course, a lot of them are in the space, so they may know. But for those who don't know, so occupational therapists' responsibility is to teach the elderly people to how to carry out the activities of daily living. Would you mind telling for the audience who may not be from the field a little bit more about what that entails?
Yeah, absolutely. So occupational therapists and occupational therapy assistants work across the continuum of care. So you'll often find them working with children and kids, and you'll also see them working with older adults. But we work in schools, we work in clinics, we work in hospitals, nursing homes, and in people's homes. So we really do span across a lot of different areas of practice. Specifically, when working with older adults, we're working to make sure that they can remain independent safely within their homes and their daily lives. So making sure they can take care of themselves, making sure that they can handle the daily tasks that they need to be able to do, such as bathing, grooming, making food, dinner, paying their bills, managing finances, managing health appointments, taking medications. A lot of things that start falling through the cracks sometimes when people start getting older and family starts pitching in, right? Let me go get groceries here. Oh, I'll take care of your bills. Oh, let me go pick up your medications. And all these things start adding up over time. And so our goal is really to assess the individual, their family, and their environment to help support independent living as best as we can.
Fantastic. That sounds like something that we need, and especially I have parents who are getting old, and I think about that. I think about how to give them the best experience. And so how did you get started in this field, and what sort of motivated you to get into occupational therapy?
Yeah, I went into occupational therapy wanting to work with children. That was sort of why I went into it. And then once I did my labs and some rotations, I quickly realized that I didn't want to work with kids. And I really started enjoying working with the older adults. I think part of it was also ingrained. I grew up with all four of my grandparents. I was surrounded by all of their siblings. And so I always had older adults around me. And I think that played a big role in just from a culture standpoint and a generational standpoint of how we take care of our elders, and especially in the US, how we don't take care of our elders. And so I think that was really one of the reasons why I got very invested into specifically working with the older adult population.
And it totally makes sense. I can understand. I mean, obviously, both of us being South Asian. So I know that in India, there's going to be a lot of family and support that are always right there. So the experience of aging is a little bit different than, maybe a little bit more lonely and isolated here in the US. So it makes sense that you noticed a stark difference and you, I guess, wanted to make a difference in that space. And I see that you're doing some fantastic work and you've got some great social media and spreading awareness on it. So I want to sort of step back. So occupational therapy sort of is a part of overall, if you look at all different types of therapy, so there's physical therapy, occupational therapy, then there's the speech therapy as well, SLP. Are there other kinds of therapies, and how do they all sort of relate and intertwine with each other?
Yeah, I mean, I could go into like all of the non-medical therapies that we have too, right? So in the medical space, there's also respiratory therapy that will often work with individuals with pulmonary issues, lung issues with their lungs, diseases, cancers, things like that. Yep, COPD. And then in the non-medical side, I mean, there's art therapists and music therapists and recreation therapists, right? These are the therapists who are working with individuals to pursue leisure or social participation interests and help them maintain some sort of activity of whatever it might be. Art and music therapists work really closely with identifying or help assisting with sometimes mental health issues and concerns or neurological concerns or issues too. And they're there to kind of offer an alternative medium for expressive therapy.
Very interesting, because I think about 2 years ago, I had a podcast with this person he had developed this program where young people would be connected with elderly people to provide them company and support, to talk to them during the pandemic time. So it sounds really interesting. Tell me more about what your company does at Aging Together and how you're able to help the elderly people and make a difference.
Yeah, absolutely. So I started Aging Together to meet a gap in the community, which to me was a gap in literacy, right? So not just health literacy, but also care literacy and understanding how our health and care systems work and how to navigate them. I've worked in crisis care and crisis management for such a long time in the hospital, right? Someone comes to the hospital because they have an infection or they get injured or they fall or they have some sort of medical condition. And usually they're coming into the hospital at a time of crisis. Now, for older adults, a lot of times that leads to more issues, right? One hospitalization increases their risk for a lot of other issues. And so then we're looking at in the hospital, our role is to ensure that they can safely discharge home. And if they can't, what do we recommend alternatively? A lot of times that includes inpatient rehab of some sort, whether acute or subacute, or we're sending them home with home health or outpatient therapy. Rarely are we sending an older adult home with no services, because generally if they become hospitalized, they're going to experience some sort of deconditioning or just some concerns related to health and safety that we want to make sure there's a safe transition home. One of the things in crisis intervention in the hospital is we don't get the time to spend to educate the families. And oftentimes with older adults, a lot of that gets lost in translation because they either forget or they don't understand everything we've told them. And then there's no carry forward of that education to the families that might be involved in taking care of them. And we simply don't have the time or the resources to be able to call every single family member or call and meet with every single family during this day to be able to properly educate them on all of our recommendations. And so that was one of my things where I was like, how do we educate the masses? How can we educate the community at large about different topics related to health, healthcare, care navigation, community resources, different supports that are in place, all these things that might be helpful and supportive for them. And that's why I started Aging Together. I started it with just a podcast. And so the podcast covers different topics, again, related to all of that stuff. I interview different providers and professionals in the space. I also interview family members who have been through the process.
So you were talking about how there's not enough time at the hospital for somebody to really educate everybody who's going to be involved, and there's a lot of times various things that must be addressed, like home safety and their ability to manage everything that they need to post the acute episode that they've had. So tell me more about that. How do you get involved, and what do you do as a next step if someone gets admitted and they're elderly? And so how do they contact you, or you contact them? How does that work?
Yeah, so in the hospital, we make a recommendation for discharge, right? And so whether that's going to rehab or going home with resources, excuse me. And so what I was saying before we dropped off was I started the company as a means for education to the general public, to the community, because I felt like families shouldn't wait until they end up in the hospital to learn about how our health and hospital and care systems work and how our insurance system works. I feel like people should know how all of that works before something happens. And so that's why I started with the podcast itself. And then with the podcast came the blog. And then with the blog came the newsletter. And so my husband always jokes that I'm building a media company because it's just a lot of education and not a lot of like direct services. But eventually what came of that is people started reaching out to me for support, right? They're like, hey, can you help me with this? Or can we talk through this? And so I started doing some coaching and consulting work with families who need a little bit of that extra guidance or want some extra education. And so now it really just looks like word of mouth. I partner with some like care managers and some financial advisors and some elder law and estate planning attorneys, so that when they're working with families who don't truly understand either their health or the care system or how to plan ahead for the future, then they'll bring me in sometimes to work with those families and provide some sort of education and projection for care.
I love that. And I love that categorization of you being a media company first, or, of course you're not, but I know that it's all about building a community and then letting the community sort of find ways that they could extract information, benefit from you. I feel like, I've been on a similar journey where, creating a podcast or even other videos, educational content is just so fun, first of all. And secondly, you get an opportunity to connect with a wide variety of people, and yeah, that could allow you to find the right people who you can partner with. So yeah, I think that's great. And I love that. I'm sure a lot of people would get inspiration from that. Like, even if you don't know exact steps, or even if you may only have a handful of clients, go ahead and try to give as much information as you can and help the community, and then they'll come find you. And I guess that's how you found and got that traction. And
yeah, I always say I've always identified as an educator first. So whatever it is, it's education.
Yeah, I still remember, this is like 10 years ago. I was in Redwood City and there was a panel discussion, and I wanted to really get my question in. And I was like, okay, what do I do to grow at that time we were a project-based company, like doing services. And they were like, okay, for services, it's really about content and community. And I was like, okay. And I took that question and I was like, wow. And I know then a few years later, I started the YouTube channel and started the podcast. And that's been really, really refreshing. I mean, I like to tell my team, I only have these 3 goals, and they sort of rhyme. It's product, which is Copper AI, building documentation, process like automation for nurses. Of course, we serve clinicians. Then there's productivity. So all the AI tools that I cannot not like learn and install and play with. So every day there's 5 to 6 hours of that. And then third one's production, like production of videos. So doing at least 2 or 3 podcasts, every week, at least nowadays. I think so that is just really. So it's product, productivity, and production. And I think, it looks like production has worked for you, and building that community is really helpful. I talked to other founders as well, and they're having similar experience. They're just being authentic on LinkedIn. They get like 1 million views, and next thing you know, their calendar's booked with like 50 appointments. So absolutely, And what I've noticed is that it's really important to focus on giving a lot of value, like not just to your clients, but to the entire community. And I've noticed that, exploring some of your content, it's super rich. So tell me about, like, why is this such a big problem and what's the impact of it? Like, give me a little bit of the lay of the land and why, it's especially important for the immigrant community as well. You talked about how, a lot of times we don't understand Medicare Part A, Part B. I mean, especially people who've been used to being in a developing country where you could have the doctor just visit you, or you could just show up at a doctor's clinic. I mean, things work very differently. Insurances work very differently, although things are changing now. I don't want to be stuck. A lot of my friends joke that are still from India. They're like, oh, you left 21 years ago and you feel like India is still there like it was in 2004. Of course, it's come a long way and we have insurances and all these things as well. But tell me more about how you sort of see the situation getting exacerbated and what problems need fixing.
Yeah, we can probably go down a whole rabbit hole with this. I
Let's
like
do
what you
it.
mentioned about developing countries, right? Because sometimes I feel like we're a little overdeveloped. There's too many hoops to jump through to get someone the right care that they need. And it should be as easy as being able to just call a doctor and they can come see you at home so that you're not sicker longer, right? You can get addressed as soon as possible. I will always say, so, since you brought up India, like I always had a very negative perception of healthcare in India because growing up, it was very undeveloped, right? It was undeveloped. And I had experiences with family members not getting the care they needed and things like that. But I went to India 2 years ago and I got really sick. And I was at a hotel and the front desk just called their concierge doctor. The doctor came, checked me out. We got imaging, we got medications, and I was on the mend within 24 hours. I mean, and that would just not happen here unless you are associated with a concierge private medicine facility, right? Like here, you have to pay a significant amount of money to get that level of quick care. And
I
that's
didn't
just
know
not
you could do
accessible
that.
to
There's some
everybody.
private concierge that you could actually get that. I mean, if you got it, I've never
Yeah.
heard.
So there's more and more of these concierge medicine clinics that are operating in the US now. So we have quite a few here in Chicago and we ourselves are part of one. And so, you pay, it's an annual membership fee and you can text your doctor when you need something or if something happens, they're kind of available to you. You can walk in if you're not feeling well. They can call in a medication. You can get it right away, but it's a pretty high fee and they don't take insurance. So like you're paying for insurance, but you're also paying for this concierge medicine so that you don't have to go through the hoops of insurance and waiting for care and waiting for an appointment. I mean, I used to have to wait weeks to go see a primary care physician because they were so busy, right? We have a shortage
We've
of
all been
physicians in
there.
this country.
Absolutely.
We've all
We've all
been
been there.
there.
Yeah.
And so by the time I get an appointment 4 or 5 days out or a week out, I'm already recovered, right? I don't need to see the doctor anymore. I needed to see the doctor a week ago. And so, just when you talk about that's what it reminds me of like, yes, there are some things that we have so well done, but some of the things that we have developed are truly overdeveloped. I think the other aspect here is that a lot of these terms are foreign, right? So if you've never worked in the system, if you've never dealt with insurance, I mean, like, I don't think my parents ever dealt with health insurance in India, right? Because they came here, they immigrated here a long time before insurance is developed in India. And so they came here and they always just had insurance through work or through the state or whatever it was. They never really had to think about it. And now, I'm hand holding them through Medicare enrollment because there's a billion plans you can choose from. They try to sell you on the ones that are going to make them the highest commission instead of what's going to be actually good for that person, right? And
Yeah.
as a healthcare worker, I know the pitfalls and the downfalls of certain health insurance plans, right? It's like,
I know,
these
especially
look
Medicare Advantage. Like they
correct,
just
right?
try to lure you in.
Right.
Yeah, I hear a lot about that. No, absolutely. And
Yeah,
you know,
exactly.
I think what you're describing, although like I want to be very honest, like I'm also very grateful for the kind of
Hmm.
care that we can get here. But I feel like I do understand where you're coming from, because that's exactly what my dad, who's in his 70s, says. He's like, Arvind, what is this? Like, over there, I just go to the hospital and everybody's available for me. Like, if I'm having a pain, there's somebody there. If I want to get my eye surgery, the one doctor just sends you, oh, okay, yeah, go here. But I'm like, Dad, everyone needs to be performing to like their highest qualification, if you will. And of course, if there's shortage, then you only get a slice of the time. And I feel like for me, I've been with my PCP for like, I don't know, 15 years. Pretty much I get a telehealth appointment same day. So maybe I, haven't had those types of experiences yet. But I do see the point, like, it's a little bit different, obviously, when you just arrive here, which is more true for me than you, I guess, because I think, your parents were already here. So very interesting. Tell me about, when you and I were talking earlier, we talked about the 53 million people who are acting as unpaid caregivers. Tell me a little bit about that. And, I got an opportunity to hear your podcast a little bit as well. It was very interesting what you were talking about as you were describing the perils of, taking care when you don't have that kind of information and education, and, what happens when things go south a little bit. Can you talk about that a little bit?
Yeah, absolutely. So we have, like you mentioned, we have 53 million unpaid family caregivers in the US, and that number is a few years outdated. So I'm sure it has grown. We have the highest life expectancy we've ever had. People are living longer. I always share the statistic that when the first baby boomer was born, the life expectancy was 65. And now baby boomers are living well into their 80s and 90s, and no one prepared them for it. And that's the part where a lot of people are not understanding that we're going to live longer and longer. And this current generation that's living longer is aging in illness. They're not well, they're not independent, they have comorbidities, chronic diseases. And so they need care and support. Now that care and support varies, right? But we don't have the infrastructure it's a supply and demand issue, right? We don't have the supply of paid care workers to support how many of these older adults need support and care, right? And so what happens is it all comes down to who can either afford these care workers or which care workers fall under insurance coverage. Everything else is left up to the families, right? A lot of times if you qualify for home health aides or assistance, personal care assistance, or whether that's through health insurance or the Department of Aging, a lot of that stuff is income based, that they're providing care maybe 4 to 5 times a week, 3 to 5 times a week, 4 to 5 hours at a time. Who's doing the work the rest of the time, right?
True.
Outside of those hours, it's the family who has to step in, right? And if the family's not there, then the older adult is just on their own. And so we're seeing this like dual problem with older adults who are managing themselves as best as they could, but they're falling through the cracks because there's nobody caring for them. And then there's the family caregivers who are taking on the brunt of this work. In the field, there's a pretty common phrase that gets used and tossed around a lot, that family caregivers are the backbone of care in America, right, in the US. And it's true, because if we didn't have family caregivers, our hospital systems, our nursing home systems, our care systems would be so overloaded that our entire infrastructure would collapse. And so, I always say, like, think about it. Like, if every single family caregiver woke up tomorrow and said, I'm done, I'm not going to do this, who's going to do it? There's nothing there.
Yeah, it's a great problem. And because we don't have enough clinicians that are available to cover, like you said, not even the home health aides, not enough skilled nurses as well. There's a huge shortage, and that has persisted for a very long time through the pandemic and even now as well. And it's projected to continue to grow.
And there's a lot of variables that are impacting that, though, right? Like in our current climate, we are seeing an attack on Medicaid services and eligibility. And so there's less people who qualify for any level of support. We don't have the infrastructure, and we're losing funding for training programs that historically would train care workers especially immigrant care workers, right? And so we're seeing a loss of those programs. We're seeing a decline in the immigrant workforce because of all
Totally.
the current issues in the US, right? And I don't have the numbers pulled up right now, but I wrote an article about how significant the portion of direct care workers are immigrant in this country. And to have that entire workforce either be fearful or be unwilling to go to work, right, because of the current issues, we're seeing a continuous decline in the supply of direct care workers even available.
Right. And I see a lot of the focus on fraud and abuse, which there may be some. And like, I know that there are cases where, even in Dallas, where I live, there were a lot of home health agencies that were just willy-nilly sending these bills in, not really providing the care. And again, there are only very few, but I think in the name of that, the rest of the population is also sort of getting shortchanged. And yes, I'm very familiar with home health and the way that last final ruling had a cut for 1.4%, but the cut proposed was much higher. So there was a lot of these organizations that brought these home health companies together to go lobby in Washington and in Austin, for the Texas specific stuff. And then that did make a difference. And I think that the tools that we have are, the elected representatives. So that's been something that, now we talk about, like, hey, discuss it with the representatives, go show up, talk about the stories and all of that. What, according to you, needs to be done to at least have some impact? I mean, all the things that you mentioned, of course, better education, more funding, but what are maybe some of the less obvious things that can be done in the current environment?
I think on investing in who can make up our direct care workforce. There are some, like you mentioned, there are some companies who are trying to tackle some of this work from grassroots or from the ground up, startups, trying to meet the demands of the care needs. We need
What do you
to
mean, like,
get creative.
right? Sorry, can you explain that more? What do you mean, like remote patient
Yeah,
monitoring?
so there's so there's this company where they match college students in the healthcare field with older adults. So something you were talking about earlier, but this company will match families with a college student in their area who's already CPR trained, has a background check because they're in a health professional program at a local college, and they'll connect them to be able to provide support to the older adult, whether that's just doing the dishes or whether it's keeping them company or getting them groceries or preparing a simple meal. They can't help with like medications or injections or anything medical in nature, but they can support all the other stuff that family caregivers often get bogged down doing, right? Like there's just so many little things in someone's day that have to get done. The dishes have to get washed. There has to be food made. There has to be groceries that are picked up. Bills have to be paid, right? Like all these things that someone can help them with. And because they're students, they are much more affordable as for the families too, right? And so there's different pay that can be negotiated because they're students and all of this stuff, which offers a more affordable option for families who are looking for some, that sort of assistance. And so I think there's more of these sorts of initiatives that are happening. Remote patient monitoring is huge across healthcare. It's huge in hospitals. It's huge in nursing homes, assisted livings, and people are starting to now utilize them in homes too, personal homes. It's just a way to have a little bit of peace of mind when you're not at home, to check in on your loved one, an older adult, to make sure they're okay. But as far as like improving stuff, I mean, it's kind of all the same stuff. Like we need more access. We need more awareness. We need more resources. I mean, and it's not that we don't have the resources. I say this a lot. We have resources. They're just so siloed. We don't work together. They're so siloed that people don't know about them. And then it takes forever for them to connect the dots and truly understand which resources they need for their needs. Because it's easy for someone to say, just Google it. But have you tried Googling help near me? I mean, you're going to get a million options. And for someone who doesn't know the healthcare system, someone who doesn't know different professions or what they do, what their roles are, someone who doesn't know what to look for or what to avoid, they're going to sit there and then they're going to give up because there's so many options, or they're going to get scammed, or they're going to end up in a fraudulent company, or anything could happen. And so there just needs to be more collaboration with the people who are doing the work to make sure that the correct resources are getting into the hands of the right people.
No, that's so true. I've been in technology all of my life, and I feel like technology's got a role to play in this as well. Again, I don't know specifically how it's going to evolve. I mean, I don't imagine there's going to be humanoid robots who could do your dishes, like not in the next 2 years. Although, I mean, who knows with the exponential growth. But then there are other ideas like that too, like obviously having some sort of a helpline where the remote caregivers can call, or that could be a helpline where somebody in need could call and get a little bit better assistance than doing a Google search. There's a very interesting thing that I think you appreciate that we're doing. As you may already know, in home health, it's about like caring for the patient for the episode, and of course, it matters. That you keep them at home, you help them with the medication management, you help them with, whatever their primary diagnosis is, whatever the PCPs requested for the focus of care, and while also keeping in mind the comorbidities. And the way that PDGM pays you is per episode, and the payment gets adjusted, the reimbursement gets adjusted based on several factors like the source of the referral, if it's from the community or the hospital, and then also the comorbidities. If they have a number of them, then that matters as well. And then several other factors that matter in determining how much the home health agency gets paid. And that's why what happens is with this new system, like earlier it was pay per visit. So then, there were nurses that would just go out there for putting a little Band-Aid and Neosporin, and you're like, all right, well, that's, a visit. But now, because of the PDGM, it's more about better patient outcomes. So what we're trying to do is, in between those skilled visits, making an AI-based phone call to the patient who then can answer some very basic questions about, are you feeling better? Is your condition better? And you could ask them certain questions. What we've tried to do is also ask them questions to understand if they retained any of the teachings that the caregiver provided. Let's say, they're a CHF patient, and then you're teaching them certain things to manage their condition, then those things, they're only going to retain so much. So you have to have a lot of repetition. And that assessment could happen using voice AI. And we've been experimenting with that as well. And then there are other technology initiatives, right? I know Suki just raised a bunch of money. They're doing good. There's all sorts of things. I was attending this conference, National Alliance for Care at Home, and there were Columbia researchers. They presented an idea, especially relevant to you because you have expertise in dementia, from 30-second of audio clip, and that's not FDA approved yet, but from 30 seconds of audio clip, they could assess the early onset of dementia. What are your thoughts on how technology could be an important piece of the puzzle that could maybe give some relief to across the board, like better outcomes for patients, more reasonable reimbursements for home health, because their margins are really dwindling, and especially, most importantly, for the burnout that the clinicians have, not just the family caregivers, which of course is a huge problem, but even the people who choose to be in this business to care for elderly patients at their home. It's just a lot of work, and it's a lot of burnout because of the documentation requirements, having proper clinical notes, or you get a lot of these audits and PCRs, and there's a lot of challenge that technology can perhaps alleviate.
Yeah, technology is, of course, embedded into almost everything that we do today. One of the things that you brought up earlier was telehealth, which was like the initial technology integrated, right? Or new technology that was integrated into healthcare, I should say. And telehealth only goes so far because you have to bank on the fact that these older adults, that they all have technological access, that they all have access to internet, that they all have the skills to be able to operate telehealth platforms and software, right? And so of course, there's pros, but there's a lot of cons there as well. With other technologies, something that the other professionals in my space and I have talked about a lot is that there's a lot of tech advancement and emerging technologies that are looking at improving infrastructure, insurance, provider access, provider tools, all of that stuff. But there's not enough technology or tech development in the space of helping caregivers. Everything focuses on the providers, which, as a provider, I really appreciate that. But the people who really need the help and support are the family caregivers. They are using reminders and notes on their phones or writing things down in diaries, and they're trying to manage all of these appointments and all the different things doctors have told them and all the different medications, and then the medication changes and their side effects, and just trying to hold their family member together while also managing themselves. And in many cases, they're caring for more than one older adult and they're caring for themselves. And so it becomes such a tedious task to manage all that information. And there's not enough development in that space to help support these family caregivers. I think there's a lot that can be done as far as streamlining information, streamlining communication, and then helping family caregivers piece together all the information to give them just a daily rundown of like, here's what you need to do, versus them having to manually go through, make a list, figure out what they need to do. And they don't understand the terminology. They don't understand the platforms. They don't understand the diseases, right? And so, yes, technology is great. I think we have so much wonderful development and innovative tools that are emerging in the care space as far as how to provide care and how to get paid for it. Not enough is being done to help support the actual family caregivers who are doing the caring more than the paid workers.
Yeah, I see your point. You're absolutely right. Because even for us, I mean, our focus right now is more to provide tools to the clinicians, the registered nurses, who are going to go out and perform a skilled visit. So we give them tools to not have to get all confused and go through 100 pages of H&P, but instead giving it to them in a prescriptive way that, hey, according to the initial assessment, here were the goals and interventions, and here are the activities, and this is how often you need to do it. So for this visit, do X, Y, and Z and mark it. So teach back to the patient and all that. However, we're not really thinking about the family caregivers, and I think there's a reason for that. See, first Scribe came to the hospitals and the doctors because I guess that's where the most money was going. But then, I mean, even as a next step, because the clinicians haven't had a lot of access to the technology, and home health traditionally is sort of, not as sophisticated, and they're very fragmented market. And it's usually, a caregiver who would start the business and then slowly grow, but they haven't really gone to, a B school or something to do things in a very systemized way. But I think these tools eventually naturally would extend to, the family caregivers as well. And I know you have this concept of pre-caregiving, like planning before the crisis hits. Can you talk some about that, what that means, and how can somebody who's caring for a family member can think about that and perhaps even use technology to do that? Because you're right about not everybody knowing all the different, like we're not all, medical professionals. I mean, a bunch of us are engineers here. So how do you go about thinking about the concept of pre-caregiving and getting a little bit more versed in some of this healthcare education, being sort of that family caregiver?
Yeah. So, to talk about pre-caregiving, I want to talk about where that comes from, right? So normally when something happens, like a crisis happens and they're in the hospital, we're a bunch of providers are going in there and offloading a ton of information to these patients and families. A lot of times, most of the time, it's the first time they're hearing a lot of this information from what kind of care they need, to what our recommendations are, whether it's for rehab or home health or outpatient, whether we're recommending 24-hour care and what that means for the family. What is it at home? Is it in a facility? What gets covered? What doesn't get covered? Equipment recommendations. I mean, everything, right? And usually something happens and in the hospital, they have like 24 hours to make a decision on something. And they have all this new information. They are trying to process it and they're in a crisis, right? So they're emotionally heightened. And so they have to try and make all these sometimes life altering decisions under duress, essentially, right? They have like 24 hours to make a call. And so the goal of pre-caregiving planning and proactive care planning is to create a plan, and plans can change, but creating a plan A with a soft plan B about what happens when there's an emergency. Who's calling? Where are you going? Who needs to know? Who has all the paperwork? What medications are you on? What mobility assistance do you need? That stuff, right? So one of the proactive care plans I do is emergency care planning. And that's for personal and environmental emergencies, right? Because older adults who live in environmentally hazardous areas, if they need to evacuate, whether it's flooding or an earthquake or tornadoes or a snowstorm, do they have a plan in place? How are they going to get out? Because that is a huge concern amongst a lot of older adults, right? The second is long-term care plan. And so, okay, you don't need it right now, but you are one fall away from breaking a hip and needing care. What is your plan, right? Are you going to get someone at home? Are you going to go into an assisted living facility or a supportive living environment? Do you have the resources to do this, right? Assisted living facilities, at least in our area, have extensive wait lists. So you can't just go to the hospital and be like, oh yeah, I want to go to assisted living. That doesn't work. You have to go through a process. There's a wait list for 6 to 8 to 10 months, depending on where you want to go. And they're expensive. And so have you made a financial plan for that? Do you have a list of your top 5 places that you'd like to go to? Have you toured them? Do they know that you're interested in their facilities? Are you on a wait list, right? Like all of these things that you need to think about well before you need it. And then lastly is end of life care planning. So it's paired with an advanced directive, but also just in general, how do you want to live out your final chapter? Where do you want to live out your final chapter? Who do you want next to you? Are there certain traditions or rituals that you want us doing, right? Culturally speaking, we have a lot of rituals when someone dies. I don't know them. Like I don't know all of them. I've seen them with my grandparents, but I don't know them. And so I have to very point blank ask my parents, like, hey, what do you want me to do when you die? Because I don't know anything about it. Right. And so then if they have all these expectations and they never voice them and I don't know anything about it, we're both in a really bad situation. Right. And we're both going to have hard feelings. There's going to be a lot of difficult conversations. And so I always say you'd rather have those difficult conversations now versus during a time of crisis, because they're still going to be difficult either way, but they're going to be a lot more difficult if there's an active crisis going on. And so those are kind of the 3 high level of like what I cover with proactive care planning.
Yeah, that sounds like super valuable. And I think for us as well, a lot of the decisions that are made, like when I say us, like in the home health space, a lot of the decisions are made by the kids that are taking care of their parents about even the home health and, palliative care and then hospice. And I think it's very important to have a plan and be educated about what are the different options in that domain. So, no, that's fantastic. Kudos to what you do and how you support the family caregivers and better outcomes for patients as well by educating them. That's how the older adults, because, we are also venturing into creating a lot of patient education through these animated videos that even if the caregiver has the time to coach them, but she may not know all of the points that need to be covered. As an example, for the fall, which is an area that you cover a lot, I mean, I didn't know that you're just supposed to lay there if you fall. But then as we created some of these videos through research, and I don't know, you can correct me if that's not true, but I think when I watched one of those videos that was produced using AI and all that, I learned that, if you fall, don't try to suddenly get up. Just stay there, get oriented, catch a breath, and, all those things. I think they're important to disseminate and make available for the family caregivers and even the older adults to make sure that we have better access to information and, better, more personalized access to, according to their condition and their comorbidities that they have, what are some of the things that they need to be educated on. So we have this video that the clinician can just show and talk about it, and then have them sort of repeat back as well, which I think is super cool from a perspective of even logging that you actually did that. It's not just about taking the vitals and O2SAT and, doing a few things, but you're actually teaching and documenting some of that. And of course, with technology, you can keep track of that and patient monitoring, then understand how much retention they're having. It's super cool. Well, wonderful, Pooja. Thank you for this. And if anyone wants to get in touch with you, of course, we're going to put a link down. Also, we'll put a link down. We'll make sure for your podcast. Any other message for anyone who is at that stage, who may be, an older adult or a caregiver, family caregivers more specifically, for an older adult, for a family member? Any message how they can get in touch with you?
Well, yeah, my message is, it's never too early to start having these important conversations with your family on what you want and how you want it. And then as far as reaching out to me, I'm most active on LinkedIn, but for clients and patients, my website is the best option, aging-together.
Perfect. And we're surely going to put the link down there. Well, wonderful, Pooja.
Thank
We
you
should
so
totally
much.
stay in touch and do this another time as well, where as we see this massive change that AI is going to bring, in the next few months and years, I think it'll be fun to compare notes and see what you're seeing with your clients and how we're progressing and solving some of these problems through technology.
Absolutely. Thank you so much for having me.
Wonderful. Have a wonderful day. Mike?
Bye.